We're going to start off with some fan mail today. I'm so excited
Good.
about this one. Yeah, because people actually send us fan mail.
They do.
That's the most
It's
exciting part.
awesome.
Yes. All right. So here it is. Just listen to the podcast over SSRI withdrawal. Oh my God. So glad people are talking about this now. I haven't been able to come off Prozac, and people have thought I was being dramatic.
Oh,
Please keep talking about it, and more specifically, what it feels like. Thank you.
yes.
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 Yeah.
We can do
I
that.
was so happy to get that. Of course, we're going to do that. So
Oh, yeah.
more to come on that. But first, did you know that only talking about your trauma can make things worse?
What?
I did know that actually. But we are your whistleblowing shrinks, Dr. Teralyn and Therapist Jenn. This is the Gaslit Truth Podcast, and we have a special guest today, Jeremy Fox, and he's going to tell us all about it.
We do. We have Jeremy. Let's bring Jeremy in. For those of you who maybe don't know Jeremy, he's a licensed professional counselor and an EMDR approved EMDR consultant. He specializes in treating trauma, and he has practiced EMDR. For those of you who maybe don't know what that is, okay, that's eye movement desensitization and reprocessing. He's been doing this since 2014. He facilitates several presentations regarding its use, and he addresses the dissociation, the flashbacks, the other symptoms of post-traumatic stress. He initially developed an interest in EMDR while working in the community mental health center, and he was made aware of the therapy modality's effectiveness in treating these symptoms of trauma. He received his EMDRI approved consultant designation in 2019. And the coolest part, his article, Recovery Interrupted, the Zeigarnik Effect in EMDR Therapy, an adaptive information processing model, was published, which is super cool, in the September 2020 issue, Journal of EMDR Practice and Research, which is like so cool to be published. Very jealous. Keep moving on because it's about Jeremy, not me. So he facilitates EMDR basic training courses. He teaches the other therapists how to reduce trauma, which is super cool through the modality of EMDR. He brings a lot of awareness to this idea of the complex PTSD that happens, especially with the violence survivors, right? Supports the vets, the first responders within this, and also brings in healthy gender dynamics and relations into play, which is super awesome. And so he's got videos, podcasts, essays. He's doing all of these things. The other thing is how technology reshapes our way that we are approaching healing as clinicians, which that is a thing, such a thing. So everybody, I want to welcome to the show, Jeremy Fox.
Hey, it's so great to be here.
We are like
Jeremy,
loving your shirt.
Yes. Oh,
thank you.
You missed the floral note memo, Terry.
Well, I mean, I've got pattern. I've got
right,
a
we'll give it to
pattern
you.
today, which normally I don't.
There you go.
Right?
All right.
Looking good.
Okay. Thanks.
Absolutely.
I do have to say, Jeremy was on my original podcast that I did some years ago, and you are the first guest that has bridged the gap to both. Congratulations, Jeremy.
Thank you. It's truly an honor. I mean that. That's amazing.
Yeah. I was like, Jeremy reached out. He's like, "Are you taking guests on your podcast?" I'm like, "Why? Do you want to be one?" And he goes, "Yes." And I was like, "Of course. Come on."
Absolutely.
It's so good. So, Jeremy is so good with EMDR. And this is the first time on the podcast that we've talked about EMDR as a podcast topic. So,
Yes.
I'm pretty excited about this. Yeah. Believe it or not.
You're the
Let's
first,
do it.
Jeremy. We talk about being EMDR clinicians, and here and there we'll interweave some of it, but we've never had somebody who is going to just talk straight EMDR with us and answer all the things that, the whole world wants to know about this intervention. So that's no pressure. That's what you're going to do.
Well, even the term interweave, you
Oh, yes.
I know, right? Damn it. Ding. Scoreboard for Jen.
Yeah. Oh, yeah. You're on the board. That's right.
Yeah.
For sure.
God.
Oh, we're keeping track. Oh, geez. I'm out.
Man.
I'm done. Today is done already. So, all right,
Go
Jeremy. Yeah. If you haven't watched our YouTube channel, you need to see what he just did. It was very EMDR cliche.
He did. It was
right?
so good.
The finger waving or wagging or however.
1-to-1. We got to get on the board, Terry. Like, let's go.
EMDR. It's not just finger wagging.
You need merch, Jeremy.
Yeah.
Do you have merch for that? Yeah.
Just
I will.
You will now.
That's got to go on a shirt. Like, please make a shirt or a mug that says not just finger wagging.
Like, yes.
Absolutely.
All right.
That's so funny. So where do you want to begin on this topic? What do you think would be a good place to start, Jeremy?
Man, well, I think a good place to start would be that kind of spicy intro almost, if you want, of how can talking make things worse? What do you think about that?
Yeah.
No, what do you
Uh-huh.
think about that?
Yeah. Well,
Yeah. We
you
we
know,
we gave that idea to you before we started. We're like, is this gonna make sense if we
yeah.
say like
And he was
open
Yeah.
like, "Wow,
talking is gonna make it
yes, let's
worse?
talk about that."
All right.
Yes.
Yeah.
Mhm.
So really, in grad school, when you're becoming a talk therapist, I mean, talk's kind of in the name. So, I love taking classes about group dynamics, and I love narrative therapy. I still do. I think it's awesome. Like externalizing problems, and but all these different models share this verbal emphasis. And so, after grad school, when I was in the trenches of working in community mental health, and I got trained in EMDR therapy, one of the big things you learn in traumatology is when you instruct a patient to talk about their trauma and they're prone to dissociate or relive it intensely, they can actually kind of get immersed in that narrative, and sometimes it can do more harm than good. So that aspect of trauma, the reliving, um, it can be really uncomfortable when you don't pair it with something that distances a little bit. And so becoming an EMDR therapist, learning the model, which it's an interrupted exposure model
Mhm.
of you're
Yep.
in it, you're pulled out, you're in it, you come out. It's kind of like a waveform. I'd work with clients and they said, wow, this is different. I'm able to take a little momentary break and then go back in, and I don't have to fear that I'm stuck in the trauma. So it's very interesting that sometimes talking, you can actually put someone into it more and be hurtful in the short term.
Yeah.
Sometimes just talking about
Hmm.
not even trauma, but negative things over and over and over and over again, yeah, it is can be very harmful to people.
Well, and
And
it's not that PE part of it, right? Like we're gonna jump right. Like I think you should talk a little bit about that because I think some of the listeners we have, Jeremy, maybe know
when
a
you say
little bit.
PE, please explain that, Jen.
Exactly. That's
Mhm.
where I was going. I was gonna just tell Jerry to explain the basis of EMDR, and here I'm using these like,
That's okay.
the
Don't use
acronyms. All
acronyms,
right, these
yes.
prolonged exposure types of therapies, right? That's what I'm saying when I say PE. So, Jeremy, can you describe just a little bit in general for our listeners, because some of them may not have too much awareness of what EMDR is and how it is not just sitting in a trauma the entire
Yes.
time and exposing yourself to it? Because this is kind of what you're describing when you were just talking about your last statement. So, can you just give a little Reader's Digest for our listeners of what EMDR is?
100%. Yes. So the EM in the EMDR refers to eye movement. And it's very interesting because now we've added other bilateral forms like tapping or even auditory that can go back and forth. But to stick on the name, so when the therapist and client have determined a memory that they want to work on to desensitize, meaning take the emotional and imagery vividness out of it, a session looks like the therapist asking the client some questions. What's the memory, the image, the negative self-directed thought, the emotions and the body sensations connected to that memory? The client dials it up like they're locking onto that memory signal, and then the therapist says, okay, notice all that, and then offers the eye movement or has the client tap or hold some little hand buzzers. And so what's happening is a dual attention process of a distraction of eye movement or tapping or whatever, and a memory, being in the memory. And so you've got 1 foot in each. That's probably the best metaphor: a foot in the past and in the present. So the client is stretching their attention, just like if your computer has too many tabs open and it's going a little slower because you're making it do a lot. That's the same impact on the human brain. It's our working memory, it's
Yeah.
called, that slows down when we add distractions. And so you're teaching your brain, okay, you're in the trauma. Here's that memory that's so upsetting that feels like you're in it, but also you're in the present here with me. And that
Mhm.
reteaches the brain. It gets that memory unstuck from that past, intrusive, state dependent, mood dependent form and into that semantic form, that form of, okay, this happened and it was terrible, but I'm not there.
Yeah.
I could listen to your description all day long.
I know. I was like, I'm gonna have to play
Poor
this back
Jeremy, I'm
and
like,
then say
wow.
this to my clients because he describes it so much
Yeah.
better than I do. I call it voodoo. So you're actually
Tomato,
I know.
tomato, right?
Right,
Yeah.
right. Like I'm like, there's this kind of voodoo, and you're gonna think a voodoo is happening, right? Which we'll have to talk about that, about what EMDR is and is not, right? I like how you talked about working memory. You had sent Terry and I some information that I thought was super fascinating before the show. And in there it talked about what happens when you start to actually almost kind of tax working memory in a way.
Yes.
Yeah.
Mhm.
And how that's helpful within this.
Yes. So taxing working memory is one of the leading theoretical mechanisms that we think is behind EMDR functioning. So the fast eye movement is added during the reprocessing phase of bringing up the trauma. And so that has a lot of support behind it. The eye movement, tapping, the distancing mechanism there is really proprietary to EMDR therapy. And listen, I've trained people in EMDR therapy who came from the prolonged exposure school of thought, where that's like it, that lives up to the name. Your client's sitting there thinking of it, dwelling on it. I have nothing bad to say about that. It's just research shows that the interrupted exposure of EMDR therapy works well. So you can have a therapy where you tax the working memory, take a step back, let the person kind of notice they're in the present, and then go back in. So the distracted, sort of interrupted exposure is also a viable clinical model, and ranks up there with prolonged exposure. So you don't have to do it that way, of being prolonged exposed.
Yeah.
As a matter of fact, and I could be wrong about this, you don't even have to necessarily talk about the trauma
Right.
in EMDR. So let's talk about that a little bit, because I think
Yeah.
that scares people. Like, I don't want to come in and rehash and re-talk about something I've already talked about. So
Right.
yeah.
Well, that's a wonderful point, and I really like to emphasize that to my clients when I'm giving my quote elevator speech about EMDR, and that's how I've gotten good at describing it. Is I try to
It's so
explain
good
it.
though.
I truly appreciate that. I mean, if clients don't understand what it is or know, they
Yeah.
really can't consent to it.
Right. There's no informed consent when you don't describe, like, yes, here's
Yeah.
what it is. Yeah. And here's the risks of
Exactly.
it. And yeah. Mhm.
So the important part for trauma-informed therapists to know when they're going to work with a client is, are you going to dissociate? Meaning, are you going to leave the room mentally and blank out when we access these upsetting, state-dependent, aversive memories? And so I really recommend doing a dissociation questionnaire with a client, like the dissociative experiences scale. Okay, there's one for adolescents and adults. I do that with clients before we start doing memory work, EMDR. So one of the things to recognize is we need to just make sure that the client can stay in the room with us mentally, is not going to exit that window of tolerance and be so out of that capacity that they're re-traumatizing themselves, that we're activating the trauma again without purging it, without venting that in some way. So as long as we know that as trauma-informed therapists, that they can stay in the room and reprocess this with us, meaning store it in that different way that's not as upsetting, then we don't have to know every element of the traumatic memory. We need to know they can stay in the room with us and keep one foot in the present and past as we go down that train track. And they can just say, we can say, what are you noticing? And they say, okay, more bad stuff. We say, okay, go with that. Because that's the up and down of EMDR reprocessing is, we offer it, we say, take a breath. What are you noticing? And they tell us, and we say, okay, go with all that. And we let their brain do what it does unless they're stuck. And we can talk about what that looks like. But it's very important for people to realize you don't have to give. And actually, as EMDR clinicians, we prefer shorter check-ins because your brain is doing the work. I tell my clients, the brain is faster than the mouth with trauma reprocessing. It's not that I don't want to hear you. I want your brain. I want you to get your money's worth, your insurance money's worth, whatever. And that this is where it happens in the brain, versus talking it out slows it down.
Yes. Yes. Yeah. And I like that you're just saying about the idea of giving a little less information. Again, how this is very different from a prolonged exposure type of a therapy, where not only have I found, at least where the clients are, we're bringing in all the details, we are listening to all the details of these traumas, and then they're sitting in it for quite some time. This is very opposite. One of the most fascinating EMDR clients I ever had was one that didn't speak.
Okay.
Very, very, very little. She wouldn't speak. It was so difficult for her. She would write a couple things down for me, but for the most part, we went into processing with her saying very, very little. Um, we were able to target a memory, but I had very little information on it. And as we started going through the process a little bit more, she became more vocal as time went on.
Right.
Because it was really difficult for her to even talk about it. So there were very few words that were actually spoken, which kind of goes into this idea of like the model of EMDR, because I will tell you, there are times where, for me, now you can tell us if this makes sense for you or not, Jeremy, but I can't always go by the book, because I don't have a client who can verbally say to me like, yeah, these are the negative thoughts. So what do you think about that when you have clients who like they're not following the evidence-based model and how we are to kind of lay some of this out? We're taught to lay this intervention out.
Yeah.
Because I'm finding that there's some gray within that.
Yeah.
At least
So,
for me.
oh no, I totally get what you're putting down. So I would say that when we ask the client, what is the negative belief about yourself that relates to this memory, or however you want to say it, sometimes that can be confusing to client. They don't really connect with that. And I become more explicitly guiding the less that they kind of have an answer to that. So, I say, okay, the self-directed negative I statement. How about that? Something that's kind of catastrophizing. It's not true, but you feel it when that trauma memory comes up. So, and some people just can't give the I'm blank. It's just called the negative cognition. It's a part of the EMDR protocol. So, if they can't give that, and I'm not gonna, stay on that hill and force that, like, no, we're not going forward until you can give me that NC, that negative cognition. If they can't, because sometimes that will come up in the throes of the reprocessing. So
yes, it does.
Yeah.
Mm-hmm.
Yeah,
Mm-hmm.
it's where the practice and the model, it's an art. There's an art to it, as Terry has said in the past, right? Like there is an art to this that doesn't always fit the model of how we've learned and been taught to do this, right?
Yeah, it's a
And
real
I
rhythm.
believe that to be very true. You almost have to
Yeah.
individualize something that we were taught, has parameters for us. So I'm glad that you said that.
Yeah, I've said before that EMDR is very artistic, actually. And I like how you said it's a rhythm, like it's an artistic rhythm, if you will. I love that. Um, and I apologize because my connection is crap right now. So if you we're just gonna keep rolling with it. I don't know. Jen, on
Here
your
on
side,
YouTube,
is it the
Terry
same
looks
way?
great.
Yeah,
Yeah.
whatever.
Yeah.
Okay.
Yeah, we'll go with
Um,
it.
so I was thinking about one thing when it comes to EMDR, and this is from the clinician perspective, and it made me think the difference between prolonged exposure, which I'm not trained in. I never was trained in. My trauma training was all EMDR, so I didn't get that. So exposure training wasn't something that I've been exposed to even with clients, and it makes me wonder if EMDR therapy or EMDR therapists, if that's what you're doing, are less likely to be traumatized by the client's story if you don't need the story the way.
Oh.
Yeah, do you follow what I'm saying? Like,
Yeah, less
because I was thinking,
vicarious
like,
trauma, right? We're not
yes, like,
getting nearly as much as we would if our
I
client
mean, we're
was
getting
going through
some.
PE.
You
Yeah.
get some, but you don't. If
Ooh.
do you guys follow what I'm saying? Like, because I'm like, wow.
100%.
Yeah.
Yeah. So from because I know burnout and, trauma from therapists and things like that, like, is a big deal. And so it makes me curious about myself. Like, I know that I've endured trauma from stories and what I've seen in the prisons and stuff like you, Jen. But it makes me wonder if I've been less traumatized than somebody who only does prolonged exposure therapy or talk therapy,
Yeah.
making things worse. And all they're doing is talking about trauma over and over again with their clients. So I think maybe do we have a new research article unlocked here? I don't know.
Jeremy, you're in charge.
Yeah.
Well, actually, I hate to
Go.
burst the bubble. There actually is an article
Dang.
by
Oh, good.
Patricia Torres, that says that EMDR therapy clinicians are not as impacted by vicarious trauma. So,
There
we
it
could
is.
delve in. Yeah, it's very interesting. That's great. I mean, of course, you could probably replicate that, right? There's
No,
probably
thank you.
research to be
You
done.
can-
Yeah, yeah.
Nope, that's good. I'm glad somebody's actually researched it. But it was definitely a curiosity as you guys were talking about this. And I'm like, wow, that makes a lot of sense to me since I've never done any other trauma treatment
Right.
besides EMDR. So yeah, that's very interesting. There's a Jen and I have been talking, we've been mulling this idea around for a while too. So do you have any insight about someone who's using benzodiazepines while they're engaged in EMDR? I know the research is out there, but there's some clinicians that are like, no, it doesn't matter. And there's others that are like, it matters a lot. And research says it kind of matters a lot. Do you have any insight into that you would like to share? Because if you do, I've got another question upon that. What are your thoughts, Jeremy?
So that's a great question. My insight on that is going to be a little limited because I don't typically I will ask clients what medications they're on. We'll talk about it. I've worked with clients who are on benzodiazepines. And I would say I don't think I've done a ton of EMDR with that, but I know that my perspective on it is work with what you have. If someone, and this is I work with an EMDR training company, and they offer like a really cool video to all the trainees that's part of the one of the weekend's trainings on addiction and EMDR therapy. And the idea that if someone is not intoxicated in front of you and you've got them there with you and they're have clarity of mind, work with that and do the desensitization work, right? If it's not contraindicated, if it's not counterindicated. So my perspective is you can try to do the work if it's indicated and ethical and the person is able to consent. And if you have to go back and retarget some stuff when they're off of the benzodiazepine medication, you may have to do that. So, but people don't come in best case scenario all the time, right? Just like
True.
Jen was saying earlier, like we have to adapt protocols to people. So that goes also with the model itself and when we offer it. Sometimes we have to meet people where they are.
Well, a lot of times we have to meet people where they are.
Yeah, I say that most of the time. Yeah.
Yeah. I mean, because we've been talking a lot. Well, I don't know if you know about Jen and I a whole lot, but we talk a lot about SSRI use and SNRI use, things like that. And we were curious about that too, and just didn't know, or if you want to join in on the conversation about how the emotional blunting and numbness of even a typical SSRI might get in the way of processing EMDR, because it doesn't just impact serotonin, it impacts your emotional center, the limbic center of your brain, which is similar to they're not similar to benzodiazepines, but the part of the brain that's impacted is very similar to benzodiazepines, which is also the limbic system. And EMDR impacts the limbic system too. So I'm like, there's like this trifecta look at all of these things. And so we were just, when Jen and I had this conversation, we were like, how effective is it really if your limbic system is blunted, by whatever medication is blunting it? What is the effectiveness of EMDR? I don't think we really know. I don't think we have the answers.
There
to
isn't
this,
a lot
but
of research out on that because we've been digging.
yeah,
I don't
it's just
think they
something.
put two and two together. Yeah, I don't.
Yeah.
Yeah, because I was like, wow, all the emotional centers and all this are all similarly impacted with all these medications. And so if you're literally throwing a wet blanket over your emotions with medications, is EMDR able to lift that blanket? Is it able to penetrate that? That's my question. That's my conversation. And I don't know if you have any thoughts, and they don't have to be research thoughts, but just any thoughts that might come to your head on that conversation.
I think no, that's a great question. I mean, if all the emotion is, as you expertly put it, blanketed or blunted out, then the client's not gonna be able to bring that up and expose themselves or desensitize themselves because they can't sensitize. So if someone it's like the spectrum of the window of tolerance kind of. It's like if someone's taking medication and they were so far up here at the top and hyper aroused, and they take medication and there's still some arousal there, emotionally speaking, physiologically speaking, that you can reprocess. Awesome, cool. And then maybe when they're able to get off the medication, there's that remainder, and you've worked on some of it ahead of time, but they were so outside that window of tolerance, they were on medication. All right.
Yeah.
But if someone else is on medication and all the emotions blunted out, you can't access it at all, then you're not going to be able to desensitize, because an exposure therapy requires some level of emotional arousal and vividness. I mean, that's what it's based on.
Yeah.
That makes a lot of sense to me. When we think about it, I really do think that this is an area of more study, because, we all have people that come in on your typical antidepressants and things like that, and they want EMDR. And it's a matter of assessing the emotional bluntness is basically what I'm getting from this. Like, how blunted out are you? Can you actually feel? Can you feel emotions? Can you
Right.
feel intensity? Can you feel vividness? Those are really good questions actually to ask. Yeah, as part of the
I
screening
agree.
process. Yeah. So maybe we've just come up with a new screener. I don't know.
Well, and that's what I think about when I think of dissociation, right? And giving that the DES, the dissociative experiences scale that you were just talking about, Jeremy, because I wonder sometimes, right, with not only that assessment, but with any kind of assessment we give people, right, is dissociation a product of the trauma, or is dissociation a product of the psychiatric med? And so are we actually
Oof.
treating the accurate, what really is root cause of dissociation? And so that's the black hole that my brain goes down, because I wonder that. And I've reached out to some other EMDR clinicians and asked that question, because I'm trying to wrap my brain around understanding that, because I've had clients that I do EMDR with and that are medicated, whether they're on an SSRI or an SNRI or even a benzo. And I will do that scale, and I take it with a grain of salt, because part of me is also like, I also know how difficult it is for you to access these emotional states.
Yeah.
And again, that dissociation you experience and how you rank on how we answer this assessment, right? I don't know if it's a product of true trauma or if it's a product of your inability to feel. And so you are quite dissociated, because that's the story of most of us that are on these drugs.
The disconnected, I think you're talking about the feeling of disconnection of self and others that often
Which is,
happens when people are on
looks a lot like
long-term.
dissociation,
It
right?
sure
So
does.
is this a
Mhm.
product of my trauma, or is this a product of these meds? And are we treating the right thing? And so there's lots of like questions we can't answer. But it bridges. I know Jeremy's like, oh my God, she talks so fast and says so
No,
many things, right? Like,
I'm really enjoying. I mean, it's tough to know where one begins and the other ends, right? I'm thinking
Yeah.
of the questions in the DES now, and some of those could apply to both. I get that. Yeah.
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 And it leads to then the next piece that we have to talk about, because we're all here in this research discussion now. So we want to hear about this accolade that truly is an accolade of being published in this journal for the Zeigarnik Effect article. You tell us about this, Jeremy. What is this?
Absolutely. So the Zeigarnik Effect is actually named after the founder, Bluma Zeigarnik, and she was a psychologist in the 1920s that was surprised to find out that a wait staff at a restaurant had better memory for their incomplete orders, like unfulfilled orders to give tables, than complete ones, right? And so she went on to look at this idea that people remember things that are interrupted or that aren't done yet better than they do completed actions or activities. And so
the list.
yes, right?
Yes.
Yeah, Bluma, she was a Gestalt psychologist in the whole school of like Kurt Lewin, if any, like for Psych 101 fans out there.
I say I'm having traumatic memories. Can you stop talking about that? That's just,
Oh yeah, I will.
oh my God. I failed Psych 101.
go with
I had to
that,
take it
Jen.
twice. True story. Yeah.
There you go.
Don't finger wave at me right now. Anyways, back to you, Jeremy.
I love that so much. Okay, so when I got trained in EMDR therapy, I picked up a book, actually. Was what that intro, you can't see it here. I'm not going to mess with my camera because I have a good angle now, but it's like the psychology book from DK, that publishing company. Shout out DK, they got great books. I'm not sponsored by them, but and I was
Maybe you
thumbing
should be.
through. It was like this Zeigarnik Effect section, and I had been trained in EMDR therapy recently, and my brain put two and two together. It's like, wait a minute, this idea that you remember incomplete actions, what does that remind us of? Trauma. Okay, because trauma is usually being trapped and unsafe at the same time. So that's what constitutes trauma. If you want to go down the Peter Levine rabbit hole, great author too. So, and then I was thinking about EMDR therapy. And so when you are receiving an EMDR reprocessing session, okay, you're having to move your eyes. That's an interruption while thinking of a traumatic memory. And then there's the metacognitive check-ins, Shapiro called it, like the metacognitive discussion, cognitive debriefing, okay? That happens when the therapist says, okay, take a breath. What are you noticing? And so traumatic memories are often encoded in this interrupted way that's state dependent, like it's something that you have an urge to completion, okay? That's a term in the literature, because there's actually quite a bit of literature out there on the Zeigarnik effect and trauma. Like trauma produces this urge to distance from the memory and also to complete it. Freud used the term repetition compulsion, right? You want to be done with what was interrupted. And so my hypothesis in this paper is that EMDR therapy actually leverages that. It leverages that interrupted reprocessing element of saying, okay, think about this. It's also called ironic processing. Okay, think of the memory, and then there's interruption. And so it strengthens the desire to go through that traumatic narrative. It's like you're trying to hold on to it while being interrupted, and you move through it, and that the brain hooks onto that and wants to go through and complete that as you're being interrupted again.
That's fascinating.
Interesting. So does that funnels then into this idea that there are these other channels that are being accessed then in the brain to help complete this memory, to clear those channels out, essentially.
Right. So it's that distancing, because again, with EMDR therapy, you're not being told, think about this, explain every detail right now, go, right?
Yeah.
Like that can make some people freeze, understandably. But with the Zeigarnik effect, it's like, okay, so think about this traumatic memory, and then you're going to move your eyes. Okay. And so then I'm going to ask you, like, what are you noticing? And so there's layers of distraction there.
Mm-hmm.
And it's almost like there's another hypothesis on how EMDR works called, this is a big one, the stochastic resonance hypothesis.
Oh, for the love. Oh my.
I know. Like, we're not going to
I'm not writing
Stop being
that
so
down.
smart. Stop it.
Well, this is what happens when you go dive into literature on something.
Yes.
I mean, so like
You
the
can't
idea that
talk normal anymore.
Yeah, right. Like
I
the
think he was
noise-
speaking Greek. It's fine. It's fine.
the noise of distraction of the eye movement, strengthening the person's, focus on the memory that they're being instructed to think of. So that's a hypothesis of it, but it's very interesting. If you put music on to study, you can kind of think of it that way too. Like there's some distraction element there, and then you're locking on stronger to a signal.
Yep. That makes okay. That was a good example. Like I can follow that one.
Right.
That's
Thank you.
yes.
Yeah. Well
you.
done.
That's the one he gives his clients.
Yes.
Thank you.
I do have a question, because I think about all these other therapies that have kind of been created. I don't know a better word, off of EMDR. Yes, the cousin therapies, if you will. And I'm just wondering what your thoughts. So I'm thinking about, well, there's different therapeutic interventions with EMDR components, and then there's like brain spotting, which I believe was an offshoot of EMDR.
Yep.
All these things. What are your thoughts on some of this? Because I'm like, listen, the OG is the OG. That doesn't mean that it shouldn't change and grow. Exactly. It doesn't mean it shouldn't change and grow. But I'm just wondering about, I don't know, what your ideas or thoughts are on this.
Yeah, I mean, I've heard of some of these, and I get curious at every time I hear about a new psychotherapy that has some sort of bilateral stimulation of eye movement. I kind of like to dive down the rabbit hole as I can. I think they're as good as their ability to summon a past memory and expose and desensitize and create present safety. So it's like you're tuning in and getting a better or worse signal depending on how you do those two things. It's like the two axes on like when you're graphing something. You've got safety and you've got the memory. So I've heard amazing things about brain spotting to the point where, and you probably relate to this, and other therapists and do too, like, oh, I'm going to get trained in that. Like the yearly, I think I'm going to get trained in this, spurt.
Oh.
And then it's like, maybe not. And then, I'm going to get trained in that, maybe not. So I've been through that with brain spotting because I respect it a lot.
Yeah. I mean, I think this is a collective experience.
It is. We can all sit in
Yeah.
this
And
shit.
then I go, wait a minute, that's going to cost thousands of dollars. Maybe not. That's
It's
how
like
I go.
collecting Thanos's rings. We want to have all the therapies. And
We
then
do. We
let-
do.
Boom.
Yes.
For healing.
Oh my God.
Yeah.
Yeah.
So true.
I feel like bowl rings, like Super Bowl rings across your
Yes.
knuckles. Like that would be a
Too.
great picture
Yeah.
when you get your new photos
With all
done,
your
too.
lettered therapies right
Yeah.
across your fingers.
Yeah.
Yeah.
Wait, remember
DBT
love,
ring,
hate,
EMDR ring,
love, hate,
PE ring.
EMDR should just be
Brain
Yeah.
spotting ring.
love, hate, EMDR.
CBD ring. All the rings.
Yeah.
Oh my God. I
Hey,
need a new
CBD,
reason for
there you
jewelry.
go.
This is fantastic. All right. Let's just be honest.
Yeah.
This is a lot of fun. Well, there was a sort of narrative going around that CBT, I guess Siri was talking. We'll edit that out, I guess. Or not. But there was a trend going around on TikTok that CBT was gaslighting yourself. And I thought that was interesting because I mean, well done CBT is not self-gaslighting everybody. It's really not. It's actually the opposite of where you're getting out of thoughts that are limited and coming from a place of fear. So it's interesting to me.
No, let's talk about that a little bit more because I don't know how deep you want to get into the CBT world, but there is a lot of chatter on social media about CBT, not so much about EMDR in a negative way. But CBT is kind of getting a bad rap right now. I think it gets a bad rap, and I've talked about this too, because sometimes it looks like it is too boxed in and too prescribed.
Yeah.
Yeah. So if you're coming out of graduate school and you've learned CBT, again, this is where that artistic science comes in, right? You can't just give somebody a worksheet and call that CBT or be so structured because you lose the humanity, you lose the person in that.
Right.
And that's probably what they're referring to, that maybe their experience with CBT has been more like that, like super structured, not client focused, like not meeting them where they are, and maybe a little too challenging. I don't know. So I don't know exactly why they're saying it's gaslighting themselves. Have you seen that part, Jen? Like CBT is gaslighting you?
Yeah, a little bit. And sometimes it's tied to, and actually this is a truth that I think I can sit with a little bit as well, is that it's such a blanket therapy.
Mhm.
You could just throw it on everything. And I think sometimes it gets a bad rap because of that. And I do. And I see a lot of that in terms of the gaslighting part, because it's like, well, you have this issue, throw CBT on it. You're dealing with this, it's like the catch-all therapy,
It seems not individualized.
which
Mhm.
as Western trained therapists, we have talked about this even on our show. And Jeremy, sometimes we get a little controversial with this because I do believe, right, that that treatment intervention seems to get thrown at everything.
It does.
And it oftentimes does. It really
Even
does.
in literature,
And
even in
yes.
research, like I'll make something up, like, do meds outperform CBT? And so even when you read literature, like when they mention therapy, like something outperforming therapy or therapy outperforming something, the therapy they're referring to is always CBT. Okay, 95%. So maybe not always, but a lot of the time it's CBT. And maybe that's because CBT does offer a prescribed structure. I've said this to Jen about
does.
EMDR. Like the protocols are protocols primarily my opinion, Jeremy, please, if you don't agree, please don't agree, is like this because you have to have a structure for research to prove something. So you have to go through the phases in the structure primarily for research for efficacy.
Right.
That doesn't lead into any artistry, of it, because when you're in session, it doesn't always look so prescribed,
Mhm.
but you have to have something that's prescribed for research. So CBT does that prescription. It does the ABC, of
Mhm.
CBT. So I don't know. I think that's where, because it is so blanketed, it gets thrown on a lot of people, especially if you're working in an institution, or like Jen and I worked in prison because,
Mhm.
we talk about liability and all that shit. So, anyway, now I'm just
Well,
rambling
in
now.
CBT is the thing to go back to some of the gaslighting and the blanket statements. CBT is something that we learn pretty heavily on in our education. Like
Yeah.
Mhm.
EMDR was not something that
That
I
was
learned
extra.
much. Yeah, that was extra. That was the add-on, right? Like the
Exactly.
Mhm.
master's degree is done, you get the license done, and then you're like, okay, what can I start
That
practicing? What
was the
can I
first
dive
bull
into?
ring. Mhm. That
Yeah.
was the bull
Yeah,
Yes.
it
ring.
was the first Super Bowl ring right there, right? Like, so I think in terms of the education that we receive, that is a more this is gonna sound it's a simple CBT is a pretty damn simplistic intervention. It's not nearly as complicated as EMDR.
Right.
And it's taught in the structure of what we learn as clinicians as one of the tools to
Yes.
use. And that is not something that like EMDR, that's a later thing. That's a
Yeah.
you're done and you're curious and you want to get add-ons and you want to be able to like take a focus on something, right? So I do think that it is kind of a blanket thing that gets used a lot. But that's just kind of my opinion on it. But
Yeah, I mean, so I think my big thing is what's your bedside manner, to use that old medical term. If a client doesn't feel that you care, I mean, it's that old statement of nobody cares how much you know
mm,
till they know how much you care. So CBT's gotten kind of this lampooned view, this caricature of, have you tried thinking differently? And it's like,
yeah.
oh, no bleep. No, I haven't. Of course I have.
You
So,
can say, you don't
but
have to bleep yourself,
Yeah,
Jeremy.
you don't have to bleep.
well, I don't know. You put the stuff on YouTube. It's like there's certain words you can't say. Certain,
Oh, well.
Yeah,
yeah,
well, then they take us out,
that's
whatever.
probably not one of them. But I mean, to be honest, it I could see why clients would feel that doesn't cover their experiences if it's not done in an empathic way, right? But I mean, I've heard
Mhm.
horror stories about EMDR therapy where clients have said, "Oh, is it this therapy where I can't stop moving my eyes and have to go through the trauma with?" And they, no, actually, there's breaks. And so I've heard people receiving very bad EMDR therapy. So it
Mhm.
is in the hands, pun intended, with EMDR, of the provider to a huge extent. And I mean, with
Scoreboard.
CBT, you really don't. Um, it doesn't. People clients need to understand. The point is not to say your struggles don't matter. It's how do we think about it in a way that serves you better? How do we get your brain to serve your life better? And I think sometimes that point's missing. But anyway, I didn't mean to interrupt if you guys were saying something.
No,
No,
that
that's
was
very well
great
said.
because yeah, and it makes me think about, uh, the therapeutic relationship is really the basis of a lot of things in the beginning, right? So, if you're just going in and starting CBT and you have no, therapeutic alliance or rapport or any of those things, which we
Right.
know are like the most important thing. Or if you go in for EMDR and you're like, "Hey, sit down, let's start. Let's start." You're that's gonna throw everything off. So maybe some of those people that had those experiences, didn't have that therapeutic alliance at all, or the
Right.
rapport, or very little, or just weren't feeling it. And then if you're not feeling it and they throw an intervention on you, what are you going to think? I am the sum of this intervention. I am not a human. My experience doesn't matter. So I think
Right.
for all of these, the therapeutic rapport is the most important thing to start with. There's some Facebook groups out there for EMDR, and they're consumer groups, and there are some clinicians in them. I just stalk it. I don't participate. I just stalk. And but the consumer stories are really, some of them are really great with EMDR. Some of them are really not. Some of them are really like, what? But
Yeah.
there's, yeah, but there's also this the theme that I get a lot is, well, I go to the therapist and we're on session 3 and we haven't even started EMDR yet. And I went to them for EMDR specific, as if they're supposed to come in and sit down
Yep.
and begin. Yeah. So I was like, well, you don't want, I mean, history, you don't want rapport, you don't want, like, you're missing so many things. But it's interesting to me because I think it's been promoted as such a fast way to cut through your trauma,
Right.
that consumers expect that this is going to be quick,
Well, and
and
clients
this is,
ask for that too, even when we
yeah,
meet,
they,
like, "How long will this take, Jen?" And they don't like my
yeah,
answer.
yeah.
Yeah, and I
I,
don't
I
know
I
for you,
talk about it
Jeremy, how
more
you
as like
yeah, describe that.
more precision than quick. Like, it's more
Yeah.
precision, more precise than it is fast. It is faster than talking because talking can make
Right.
it worse, as we were talking about. But it's not fast. Like, you're not going to cut through your decades of trauma in 2 sessions. Likely, your EAP is not going to cut it for you here.
Uh-huh.
Your
Oh,
EAP sessions. Yes. So, what are your thoughts, Jeremy?
I'm with you on that. I think I have to describe to clients like this is what the model looks like. We have, and even in today, my summary of it, like I was talking about the special sauce, the work that people usually refer to when they talk about EMDR therapy, because that's kind of the proprietary stuff of the eye movement and holding the trauma in mind. But that's phase 4. So to be
yeah.
honest, that's not even like there's history taking, there's preparation, there's where you get the elements of the protocol together and then send the person into the memory. All of that takes place before. And so the expectation setting, and this is such a huge topic, it could be its own podcast in the therapy world, of how much of the consumer mindset is being put into a medical psychological healing paradigm where you just that they're incongruent, right? So you have to sometimes look at slower is faster with trauma work. There's no way around it with some people, especially those who have CPTSD, complex PTSD, developmental trauma, in other words, and dissociation, where you can trigger that like a game of Operation. You hit the corner, someone freezes up. It's like, so for their safety, there sometimes has to be a slower approach where you have them think of an element of the traumatic memory versus the whole thing. And so explaining, like, I'm not holding you back to make more money for more sessions. Let's get that out of the way, right? Because I can see why people would think that. But
Yeah.
it's because if you keep, and this goes back to our earlier thing, talking about it being re-traumatizing or dwelling on it being re-traumatizing, we have to gatekeep how much we dose them of the desensitization so that their brain takes it as useful and outside the comfort zone, of course, but not putting them all the way back in the traumatic memory. Remember, 1 foot in each, one in safety, one in trauma. So that's on us to communicate it, and it's on the client to join us and seeing, okay, psychotherapy is different than taking a pill and it immediately going into effect. Even with medication, you have to reach steady state, and that takes several doses. So I think it's an ongoing conversation about how much of marketing and consumer mindset can be projected into the therapy healing realm. It's a philosophical conversation.
Yeah.
I like that. I like that a
I
lot.
do too.
Yeah. So what is something that you learned that now you've come to understand is not the truth in your field or with EMDR?
So if my field, it's that talking about trauma is always the answer. So we talked about that. I think I've actually gained more of an appreciation for CBT in hearing about like that whole controversy of gaslighting, because to be honest, I never gravitated toward it heavily in my own
Okay.
training.
Yeah.
But now there's trauma focused CBT as a
Yeah.
model, and I have not been trained in that. I've dabbled in looking at some of the stuff, and I have a lot of respect for that. And sometimes you have to meet people there. I mean, so another thing, I was I had a really, I went to a good graduate program. I'm not throwing shade there, but the idea that therapy is even, it's called psychotherapy, right? And so now we hear about somatic therapy, but just the idea that therapy is limited to the brain, it isn't, right? There's so much now involving movement based therapies. I mean, the Body Keeps the Score talks about yoga, tai chi, qigong. I graduated grad school before I really delved into that stuff and like took the red pill on somatic psychology. And sometimes that's where people have to go because they're so alienated from the body.
Yes, I like that. Is there anything else you'd like for people to know or understand?
That's great. If you have, and this is something I really feel passionate about. If you feel that therapy hasn't worked for you and your therapist hasn't done a model that helps or hasn't understood you, please be aware that there are so many different therapists, just like there's different personality types out in the friendship world. You might get along with one person and not another, and there's so many different therapies as well. Everything isn't going to be cognitive based, everything isn't going to be emotion based. Find what works for you, see what works best for your diagnosis, if you know it, or your symptoms even, because there's too many good models out there that are neuroscience based now, for people to feel like something like that there's no help for them.
So I'm going to summarize this. Take back your personal agency. You have choice, and you have choice in your modality. Yes. All right. All right. Okay, so I think we're gonna wrap up this episode of the Gaslit Truth.
go.
So thank you so much, Jeremy, for being here and sharing all of your wisdom. It was super fun. Yeah.
Yes.
Yes.
Thank you. I love
Nice.
this.
If you're listening, please make sure you like, subscribe, comment, share, and send us your Gaslit Truth at the Gaslit Truth Podcast at gmail.com. Don't forget, rate us. Only 5 stars are acceptable. So if you're going to rate a star, it better be all 5. And that is a wrap.
That's it. Thanks, guys.